It's time for another 3-question warm-up. Let's get going. First question here, which embryologic structure of the heart gives rise to each of the following adult structure? So first we have the ascending aorta in the pulmonary trunk. That's going to come from the truncus arteriosus. Next we have the coronary sinus. That's going to be derived from the left horn of the sinus venosus. And then next we have the superior vena cava, and that's going to be the right common cardinal vein and the right anterior cardinal vein. Next question. What is the karyotype in Klinefelter syndrome? What is the karyotype in Turner syndrome? So remember, in Klinefelter, that's going to occur in males who are genetically 47XXY. Now, as a reminder, these patients are very tall with long extremities. They're going to have some testicular atrophy and gynecomastia. Those are going to both be common presentations in Klinefelter. Then we have Turner syndrome. That's going to occur in females who are 45XO. You might recall these patients have short stature, a neck webbing, and a shield chest. Next question. Which amino acids are found in large concentrations in collagen? So remember, in collagen, you're going to find lots of glycine, lots of proline, and then hydroxyproline. All right, that's it for the warm-up. Let's get to that lecture now.
Hello everyone, I'm Dr. Shuford. Welcome to our Step 1 video on other gram-positives. Just like the title suggests, this is a crazy grab bag of bacteria. But some of them are really cool in a disgusting sort of way. So let's just jump right in with Corynebacterium diphtheriae. Okay, remember the gram-positive algorithm? Now look at the section labeled rods and you'll see Corynebacterium listed there. So here's a photomicrograph with numerous gram-positive rods. This is Corynebacterium diphtheriae. So diphtheria is caused by infection with this Corynebacterium diphtheriae, but many of the clinical manifestations of the infection are due to its exotoxin production. Diphtheria toxin is an ADP ribosylator of elongation factor 2. We talked about this in a previous lecture about bacterial toxin production. Do you remember any other bacteria that used a similar mechanism to inactivate EF2? Remember that Pseudomonas produces an exotoxin, exotoxin A, that has a very similar mechanism of action. Now this diphtheria toxin can damage nerve cells and heart cells, but the most striking manifestation is this pseudomembranous pharyngitis that it causes. What you see is a whitish oropharyngeal patches that eventually coalesce into a grayish, tightly adherent membrane that's adherent to the posterior oropharynx. When scraped, it can bleed profusely. This membrane can proliferate within the respiratory tree and be associated with mucous membrane inflammation, which causes the so-called bull neck of diphtheria. Obviously, this is all very bad for respiratory function. Diagnosis of diphtheria requires growth of gram-positive rods on culture and proof of toxin production. We don't see diphtheria very often in the United States because we immunize children against it. This is the D in the DTaP vaccine or the DPT vaccine. However, diphtheria circulates widely in other parts of the world, so it's necessary to know a little bit about it. How do we treat it? Well, it's a little tricky because of that whole toxin production angle. Infected patients need not only antibiotics to kill that bacteria, but they also need antitoxin in order to inactivate the toxin. Antibiotic therapy usually entails erythromycin or penicillin. You also need to give these folks the vaccine after they start to get better because natural infection doesn't induce protective immunity. Okay, so that's it for Corynebacterium. Now let's move on to Bacillus species and Clostridium species. But before we do that, I want to take a second to talk about spores. So why would bacteria want to make spores? I think the better question is why wouldn't they want to make spores? Spores are really tough. Spores provide resistance to dehydration, to heat, and to chemicals. Despite these obvious survival benefits, only certain gram-positive rods form spores when nutrients are limited or the environment becomes inhospitable. And the ones I want you to remember are Bacillus species and Clostridium species, which leads us to this photo. Here you see spores from Bacillus anthracis, the bacteria that causes anthrax. And in this next photomicrograph, you can see spores forming at the very end of these gram-positive rods. These gram-positive rods are Clostridium tetani, the bacteria that causes tetanus. You can see the spores at the end of the rods give the bacteria that drumstick-like appearance. We're going to talk more about Clostridium and Bacillus right now, but another spore former that I want you to know about is Coxiella burnettii. Coxiella is a rod-shaped organism that causes Q fever, and we're going to talk more about it another day. Okay, so now let's tackle Clostridia. Clostridia are spore-forming gram-positive rods that are obligate anaerobes. There are 4 main Clostridium species. that we're going to cover here. The first one, Clostridium tetani, makes tetanospasm or tetanus toxin. We talked about this one in our bacterial toxin lecture. Clostridium tetani forms spores that can be harbored in the environment for long periods of time. Once it is inoculated into a wound, the spore transforms to a gram-positive rod that can produce tetanospasm. This toxin blocks the release of inhibitory neurotransmitters and results in that increased firing of motor neurons and trismus, also known as lockjaw, that tetanus is so famous for. We have a few tetanus cases in the U.S. Because here in the U.S. vaccination rates are high. In general, people need tetanus boosters every 10 years. If a patient seeks medical care for some wound and hasn't had a booster in the last 5 years or more, then it's recommended to go ahead and give them a booster at that point. Okay, let's move on to the next Clostridium species, Clostridium botulinum. This species produces a heat labile toxin that inhibits acetylcholine at the neuromuscular junction, causing a flaccid paralysis. And remember that we don't recommend giving honey to babies because honey can contain Clostridium botulinum spores. These spores can transform into reproducing bacteria, which can eventually populate the whole intestine and produce botulinum toxin that causes a symmetric weakness in babies. Now for Clostridium perfringens. Remember that this one can produce alpha toxin, a phospholipase that causes gas gangrene and myonecrosis, as well as an intratoxin that's responsible for a large number of food poisoning cases. And the fourth type of Clostridium is Clostridium difficile, more commonly referred to as just C. diff. This, like the other Clostridia species, C. diff is a gram-positive, oxidase-negative, spore-forming bacillus. It makes two major toxins, toxin A, also known as intratoxin, and toxin B, or cytotoxin. Toxin A binds to the brush border of the gut and leads to intestinal fluid secretion and inflammation. Both toxin A and toxin B then enter into the cell and cause cell death. This results in C. diff colitis, usually manifested by diffuse watery diarrhea. It can even lead to dilatation of the colon called toxic megacolon, anticolon perforation. What's the primary risk factor for developing C. diff colitis? Antibiotic use. Anytime you have a patient with new diarrhea while on antibiotics, you need to think about C. diff. And C. diff colitis can even occur after they've completed their antibiotic course, so you should ask about recent antibiotic use. Clindamycin is a very common culprit, but any antibiotic can do it. How do we test for it? We check for C. diff toxin or for toxigenic C. diff by PCR in the stool. And how do we treat C. diff colitis? Metronidazole and oral vancomycin are the first-line treatments. Metronidazole for mild C. diff colitis and vancomycin for severe C. diff colitis. Metronidazole can be given orally or intravenously because the metronidazole is excreted into the bowel and can treat infection there. Vancomycin, on the other hand, is not excreted into the bowel, so IV vancomycin is useless for C. diff colitis, but oral vancomycin is perfect for this. If you think back, we usually use vancomycin intravenously for staph infections because the drug isn't absorbed from the GI tract, which happens to be perfect for C. diff colitis. We want the drug to stay there in the GI tract and treat the C. diff there. And now let's talk about the other spore-forming gram-positive rod, Bacillus anthracis. This is the aerobic gram-positive rod that causes anthrax. Bacillus anthracis produces anthrax toxin with three components. These components are edema factor, lethal factor, and protective antigen. Now, anthrax can cause different syndromes depending on where the spores land in the human body. There's alimentary tract anthrax, cutaneous anthrax, and inhalational anthrax. Let's talk about cutaneous and inhalational anthrax here. Cutaneous anthrax is the more common form. This occurs when spores get under the skin, usually through a small skin wound, and a small papule appears first, which then transforms into a large, painless ulcer with a central necrosis, seen as a large, depressed black eschar. There's often a significant area of edema and erythema surrounding that ulcer due to the toxin production. Here's an image of a woman with Bacillus anthracis infection of the soft tissue around the eye. This is a good example of the soft tissue edema that occurs with this disease. Now here's an image of a cutaneous anthrax on the neck, and this is a terrific example of that large necrotic ulcer with black eschar. Here's actually one more picture of a cutaneous anthrax. So this lady apparently worked in a goat hair processing mill. Cutaneous anthrax occurs as a result of handling animals or animal products that contain the Bacillus anthracis spores. And here, the spores were in the goat hair. The other form of anthrax you should know about is inhalational or pulmonary anthrax. If anthrax spores are aerosolized and are small enough to reach all the way down into the alveoli, they can be phagocytosed and taken into the mediastinal lymph nodes. While there, the effects of the toxins are seen, and what you see on chest x-ray is usually mediastinal widening. The bacteria can then enter into the bloodstream and cause widespread infection, sepsis, and death. This form of the disease is sometimes called wool sorter's disease because the anthrax spores contained in the contaminated wool would be aerosolized and then inhaled by workers dealing with the wool. These days, we've all become just a little more concerned about the weaponization of anthrax spores as a means of transmission. Okay, so you may have heard me just mention that Bacillus anthracis is an aerobe and that Clostridium tetani is an obligate anaerobe. So let me explain a little more about this division before we move on. Bacillus anthracis can grow and produce energy in an oxygenated environment. Now, it is not an obligate aerobe. An obligate aerobe has to be in an aerobic environment to grow and produce energy. Bacillus anthracis happens to be a facultative anaerobe, meaning that it can also grow in an anaerobic environment. Clostridium tetani, on the other hand, is an obligate anaerobe. This means that Clostridium tetani cannot grow or produce energy when oxygen is present. Other bacteria that are obligate anaerobes include Actinomyces, which is included on the gram-positive algorithm that you've been so diligently studying, as well as the gram-negative rod Bacteroides. So just as a reminder, what antibiotics do we typically use for anaerobes? The classic ones that should come to mind are metronidazole and clindamycin. Okay, moving on to Listeria. Listeria is another gram-positive rod. This is an electron micrograph of Listeria in tissue. Listeria enters the body through the GI tract where it penetrates the intestinal mucosa and is eventually taken up by monocytes, which is hinted at in the name Listeria monocytogenes. It's a facultative intracellular organism. The way that Listeria gets into the GI tract is through unpasteurized milk and cheese and contaminated deli meats. Now, if a pregnant woman is infected, that bacteria can cross the placenta, resulting in fetal loss or in newborn sepsis. Remember what 3 organisms we said to remember for newborn sepsis? That's right, Group B strep, E. coli, and Listeria. This is why pregnant women are told not to eat soft cheeses or unpasteurized milk or even to eat deli meat during pregnancy. So who do you think is at risk for Listeria infection? Well, we already talked a little bit about this one, but it causes disease in the very young, the very old, in immunocompromised patients, and in pregnant women. Okay, so take a look at that gram-positive algorithm of yours again, and you're going to see at the very top that there's a section for branching filaments. These are gram-positive organisms that have filamentous growth that resembles fungal hyphae. Here's a photomicrograph of an actual brain abscess that shows Actinomyces israelii using fluorescent antibody staining. You can see the shape of that filamentous growth. Actinomyces are anaerobic organisms that can colonize the oropharynx and the GI tract. Usually they don't cause any problems, but we've heard that story before about a lot of different bacteria, haven't we? So occasionally Actinomyces will cause cervical facial disease. That's disease around the face and neck, and usually it's in the area of the mandible. So if you look at this photo, you can see how this man has developed an Actinomyces infection near the temporomandibular joint. Usually what you see is inflammatory changes on the skin, then development of sinus tracts that drain pus and sulfur granules. Now, do these granules really contain sulfur? No, they contain clumps of Actinomyces and dead white blood cells. But remember what we said about Actinomyces israelii. Israel has yellow sand, so Actinomyces israelii has yellow pigment that can be seen in the sulfur granules. Do you remember the other bacteria that we said also had yellow pigment? So remember Staph aureus. Aureus means gold. And finally, let's talk about Nocardia. Nocardia is a gram-positive filamentous rod that's partially acid-fast, meaning that it stains with the acid-fast staining used for mycobacteria. And this is usually the clue that you should look for in test questions. Now, its shape looks a lot like Actinomyces, but it's aerobic, while Actinomyces is anaerobic. Nocardia is everywhere, in soil, dust, decaying vegetation, everywhere. It usually causes infections in immunocompromised patients, either by inhaling it or having it inoculated into skin through trauma. Here's a pretty severe example of cutaneous nocardia, but a good example of the skin lesions that you see with it. All right, so that's really about it for the other gram-positives. So let's go through the end of session quiz. Go ahead and turn off that video, answer the questions, then turn back on the video so we can go through the answers together. Okay, let's go through these questions. Which gram-positive organism matches the following statements? The first one, the gram-positive organism that causes scalded skin syndrome, Staph aureus. The epidermolytic and exfoliative exotoxin of Staph aureus causes this. Gray-white membrane in the posterior oropharynx of an unvaccinated child, that's Corynebacterium diphtheriae causing diphtheria. Pharyngitis resulting in glomerulonephritis, we're talking about group A strep or strep pyogenes. The most common cause of meningitis, Streptococcus pneumoniae. The most common cause of osteomyelitis, Staphylococcus aureus. Serious newborn infections, remember the three, group B strep, Listeria, and E. coli are the three that we went over again and again. But just a reminder that E. coli is a gram-negative. Infant with poor muscle tone, think of Clostridium botulinum and botulinum toxin. Diarrhea after using antibiotics, think about Clostridium difficile. Respiratory distress in a postal worker, well, what we're looking for here is Bacillus anthracis causing pulmonary disease. You know, right after 9/11, there was a lot of concern about inhalational anthrax being spread through the postal service as an agent of biological warfare. Otitis media in children, if it's bacterial, think strep pneumo. A lot of times otitis media is viral, though. And cellulitis, think about Staph aureus and Streptococcus pyogenes, or group A strep. Okay, next, what patients are susceptible to Listeria monocytogenes? Remember that the very young, the very old, the immunocompromised, and pregnant females are susceptible. Also remember that Listeria can cross the placenta and cause fetal demise. Okay, next. Which bacteria are spore formers? The spore-forming bacteria that we went over are Bacillus and Clostridium species. So Bacillus cereus, Bacillus anthracis, Clostridium perfringens, Clostridium tetani, Clostridium botulinum. And you should also remember Coxiella burnettii. What medications are commonly used to treat C. diff colitis? Metronidazole or oral vancomycin. And that's it for our end of session quiz. And now we have one rapid fire fact for you to remember. Branching filamentous gram-positive rods with sulfur granules. That's going to be Actinomyces israelii. That's it for our video on other gram-positives. I'll see you next time.